the full arch restorative program, we put it together. It's just that this program came in mind for mainly one reason. As many of you are working with me and have discovered more and more of our patients are in need of this. Not that we diagnose them, but they are in need of the consideration and the option of this full arch restorative program. So, I started with this before we go to our video presentation. And by the way, let's start with saying welcome to Dr. P's Dental Hour. That's important. I've been doing this for a year and a half, so I love it. I'm enjoying it. So, so this full arch restorative program is basically my way of saying I'm putting all my knowledge, everything that I have into 3 courses that would be in detail giving us a sense of how to diagnose a patient potentially for either saving their teeth with what they have with the old traditional means, or potentially taking the next step. And that next step could be an All-on-4 or other restorative options that could exist that we can study by looking at case after case. Beyond the first 3 months, once a month we'll have the gathering. Each month we will share cases among each other on the platform, so we learn treatment planning, each individual case. And beyond that, we will go into the next phase, which will be monthly getting together. It will be a course on different cases as we move forward, and we take those cases and learn and make ourselves become better at diagnosing these cases and help our patients. So next, so the unique learning program for us and for any dentist who wants to be involved. It's a small group. I learned this from Spear. 7 members, colleagues get together, interested in growing their clinical skills, predictably treating larger and more complex cases. So it's not going to be all-on-4, but looking at all the options, including if the case merits an all-on-4. I can tell you many situations have led to that when we diagnosed and treatment plan a fixed supported implant case. And unfortunately, patient's financial situation did not allow him to take that direction, and therefore considered if all-on-4 hybrid because of financial reasons. Again, it didn't mean that that patient was going to lose teeth because of all-on-4, but the consideration was there. Let me see, did I miss one? Yeah, and growing a practice. Some are looking at it that way, being able to incorporate these cases into their practices. In my situation, the growing part of the practice is the growing skills of helping the patients. These cases are very involved, especially on my end because I'm the quarterback. It takes almost 10 to 12 hours per case of treatment planning, financial planning, scheduling, coordinating IV, lab, and getting the case move forward. It's more the pleasure that it brings to me, and I mean it. It will cover patients with terminal dentition or with edentulous state. There's a case I have here and a colleague that is our mutual case. It will cover our options of full arch solutions. What are the solutions, which includes fixed hybrid, bar retained overdenture, locator retained overdenture, could be a full traditional denture, could be a partial. We'll look at all those options case after case. And again, the excitement is our own cases would be part of it. Understanding the pluses and minuses of treatment modalities. So the way I laid out the program, mainly very straightforward. I think number one, how to diagnose which teeth to save or not, and looking at the mouth as a whole, the patient as a whole, plus case acceptance, how to value and how to support the patient to move forward. I have a video here. I'll show you. Hopefully I can play it tonight. Last time I couldn't. But then the second part would be surgery and conversion, what's involved, so you can visualize it when you see the case. Right from the go, what would be involved? You don't necessarily have to go into detail, but you sense the direction the case goes, gives you a comfort of the end result. And the final restoration and the review, pluses and minuses, and what the patient's experience was. After the first 3 months, it's a 1 year of a monthly courses with hands-on patient participation. You can be over the shoulder, or what I've created, some have experienced it. I've created my iPhone over my head as an over the shoulder. So you can come and watch with patient's permission. And of course, in-depth lab instruction and a platform we can discuss cases regularly. And now, there is some of you here are part of that first group that we're going to start very soon. And anyone who's interested to join the next group, which will be in 3 months, let me know, and or let Jennifer know, and she will add you to the list. And because only 7 can participate, and most important of these 7 who are participating, within the next 3 months, you need to not necessarily diagnose, find cases, bring it to me. We can share, because the asset about this program is everyone shares their cases in terms of diagnosis and in terms of progression of the case and finish up the case. If you think about it, 7 members will share 7 cases, complete 7 cases together, which means they did 7 cases, each one of them, which is part of what I went through when I was trained as a peri-resident. We shared cases, and that's how it was very fruitful as a residency. While they were doing, seeing 1 patient every 3 to 4 hours during those years in dental school. Any questions so far before I jump into the video? Oh, I'm sorry. Well, let me do the cases first. Here's Mike, an older gentleman who was referred to me because he needed teeth extraction and discussed implant replacement. He had been very older gentleman in his 70s, denture for 20 years. This is not uncommon. A partial denture, you may call, or transitional denture, because it had been repaired and repaired. And many of them go through this process. And ultimately, we went through multiple consultation visits, because it's the process for them to understand what's involved. And between doctors, in this case, it was 2 sessions of doctor discussion and treatment planning until he felt comfortable to move forward. And in this case, this is the way he started. This is how it looked in his mouth, with some roots remaining. The clinical crown had broken off. This is what was remaining when he came to see me. Of course, we can see very common supraeruption of the mandibular anterior teeth, collapse of the bite, and how lucky he is that the second molars on the left are holding the bite. And this is how he ended it. You know, we're having, one thing I can tell you as we learn from each other, these hybrids, we have to be, to teach a new lifestyle to these patients, because he has a habit of staining. Every time he comes in for his maintenance, he has stain on his hybrid denture. So the upper and lower, we did it all in 1 day. Now you may ask, why involving the lower? The reason is the occlusion. the lower anteriors, they were so super erupted. And in order to have an ideal maxillary occlusal scheme and aligned positioning of the anterior teeth, we discussed with him the mandibular anterior issues and how some of these teeth were already compromised with restoration. And he felt comfortable to do both at the same time. I can tell you with experience, most of them start with the upper and then they say, oh, I like it. When are we going to do the lower? So,
I have a question for you, Alfred.
Yes.
So when patients say to you, I want to do the upper and not the lower, then how do you build to that lower dentition with all those super erupted teeth?
Prepare them, work with the dentist to cut down the prosthesis, whatever it takes. But your comment is well, thank you, Susan.
Yeah, because I mean, it's like
we prepared them. Here's the video I'm going to show you of the guy I'm going to show you. He was one of those. He said, let me start with the upper and later on deal with the lower. And when we did the conversion, we had to reduce the provisional fixed denture on the immediate implants so significantly that the acrylic became thin, that later on the acrylic broke.
Yeah, I know. I mean, I'm sure there are times when you say we can't do the one arch without doing the other. It's going to fail.
Course. I think that's what you meant. Yes, absolutely. Yeah.
I run into this too.
Now,
I only want to do one arch right now. We can't do that. Save money a little longer.
Now, in this case, the All-on-4 became an All-on-5. The reason was the angled implant bypassing the sinus at 30 degrees. The bone was too soft. Even the 16-millimeter implant I couldn't get primary stability. So I locked out. I was able to engage that further posterior implant into a good corticated sinus bone. So with that, we were able to load an All-on-4 and do the conversion, and it worked very well. So that's why nowadays we call it an All-on-X. It could be on 4, on 5, on 6, as many. But there is one factor that's real. They can't be right next to each other like natural teeth. It has to be spread out because we have to think about design and hygiene. One of the issues with this and the video that we're going to watch tonight, educational one, is on that. What's the long-term success of these? How can we learn from the past in order to make these more successful? And this next picture is the one that shows you another. He comes in every 6 months to see me. And again, remove the stain. This is another time he was in, I removed the stain. This is another case. This is a female patient who had been edentulate for 38 years. No, actually since she was 38 years old. And she's definitely, I'm trying to remember, in her late 60s, early 70s. My colleague whom I worked with is here. He's very welcome to step in and say hi. And it was one of those we had to plan out what to do. And we decided to approach it differently. The reason is there were, here's her smile with her old denture. I'm moving forward because I want to show you the panorex. This is the denture inside. She was unhappy because the denture, it wasn't for aesthetics, it's because mainly function. It was getting loose and gagging. It was gagging here as well. So I'll go slow so you can look at the picture. This is her lower arch. Yeah, the edentulous ridge had settled in, so we had lost some height. Manageable. Wasn't easy because we had to work with short implants, which we are lucky we have, and they can be successful if they're designed and treatment planned correctly. And this is her case. All-on-4s, we need to be able to, number one, end the platform of the most posterior implant in an area of the bicuspid at 30 degrees and have the ridge for it. And in this case, we decided to do it different. We decided that this patient would benefit more with an overdental locator. So we went ahead, did a sinus augmentation while she was still comfortably wearing her denture. Amazing patient. Then placed the implants, let it heal, covered. I don't want the denture ever to cause any pressure, failure on the implants. And then put the locators on it. I pause here just to, as you're wondering why locators, why not bridges? First of all, we did lose anatomical structure over the years. So fixed bridges could have been a challenge. But another factor is, this is how she came to me 6 months later. See how clean that soft tissue is? No inflammation around the implants. This is not what you see when you remove an All-on-4.
This was why she chose that. She was concerned about the hygiene issues, right from the beginning.
Yeah, some patients we try to push. We had another one with another colleague, push them towards this case, but they keep hearing this advertisements on TV. Teeth in a day. And I'm going to show you the next picture, which is the one that I think you will all appreciate. Look how clean the denture is, or the prosthesis, should I say. When it goes in, it's fixed, if you think about it.
Is this the case of the month that you sent with the lady?
Yes,
oh, okay. Yeah.
Yeah, because I brought it up. This is not the day of delivery. This is the 6 months later after a delivery. I do 6 months follow-up on these patients. And again, it all means a lot to us to understand it, to guide the patient in the right direction. This is the lower arch. So with those short implants, a fixed bridge on the lower right, and Steve did a beautiful job on the single molar on the lower left. She was happy with one, first molar, and again, the option was given to her. Later on, she could have a second molar implant replacement, but for the moment, so far, she's happy with what she has. And this is what it looks like now in her mouth. Now, I can tell you, not necessarily true, but there are some All-on-4 that look like this, but they're fixed. And there's no way to clean underneath them. In order for this to become All-on-4, either a combination of open the bite and ridge reduction. We need a dimensional restorative space of 15 millimeter minimum for the prosthesis. Any questions so far, team members? Yeah, Brent, any thoughts, any input?
No, everything is following pretty much what I've seen with my other patients, and heard in other studies and whatnot that
Good.
There to clean and maintain is really critical. So you have to have ridge reduction.
As a course we'll listen tonight, but one aspect of All-on-4, and this I know, and not that many surgeons or people would want to accept or share it. It is an All-on-4 for next 5 to 10 years. You may say 10-year All-on-4 if we are lucky. And I knew that I had been exposed to this research until an orthopedic came to me as a patient. He said, oh, we call it 10-year hips. Even the orthopedics average a hip replacement success for 10 years before mechanics, anything could lead to problems.
Called cunning down. Haven't changed their ads.
I know, they won't say that.
Or life, if you don't live long enough, right?
It's well, one thing I realized with them too, which might have to do with us too, is they delay that hip replacement as long as they can.
Yeah.
With injections, whatever it takes.
Right.
And they avoid to do it early in life. Yeah. Let me see. Let me now share with you guys the other screen.
Hey.
I hope the sound will come across. Let's try it. No, not yet. Let me see. Oh, it didn't come across. Too bad. I can't play it. Well, next time. Basically, how special he is. He talks about he delayed his replacement. He's one of those. He did the upper and then did the lower, and for a good 6 to 9 months. And at the end of the day, he finished with the first one. This video is 2 weeks after his upper arch, and he says he realized we are so materialistic oriented. We think about the car, the TV, the couch, but we don't think about our teeth and how important it is to us. And he recognizes that the transformation of how people look at him now, just in a provisional phase, and how even his appearance has changed. It was very, again, this is why it's so exciting to do some of these cases in my practice. I always like to say I'm a periodontist. I love to save teeth. But at the end of the day, when these situations come, it is wonderful to be able to help them. All right, let's see. Since I couldn't do this one, I know the other one, I have it on the iPad. Let me stop here. So now we go, get you guys join, share the iPad with you guys, and then we go on our presentation tonight. Before I do that, any thoughts, no, you're being so quiet. Okay, well, we all love to learn. That's why we're here. Okay, let's share the screen. Go. And it did.
Welcome, everybody. It is a pleasure to be sharing with you guys some thoughts, some ideas, some concepts regarding the management of complications. You know, we seldomly speak about complications, and I believe that very few topics allow us to learn more about what we do, like talking about complications, because this is the real deal. It's the real real dentistry. This is what we see. This is what happens, and we got to be ready. And having said that, in order to frame the webinar here, let me, you know, we are still, and we will be in this COVID era for quite some time. And it's interesting to see, you know, how we're behaving as, of course,
please go on mute.
But also how are we behaving as patients as well, and how our patients are behaving. And probably many of you were exposed to the New York Times article on the increasing prevalence of cracked teeth. And so the other day, with Instagram, we conducted a poll through our Spear Education Instagram. And we asked a very simple question. Are you seeing a higher incidence of cracked teeth? As you'll notice here, 82% of those that decided to take the poll said that yes, they are. In fact, if you want to see the numbers, we had 144 people vote for yes and 31 people vote for no. So 82% of clinicians are seeing more cracked teeth. And I have to say that I'm one of them for sure. So why is this important? Because we're talking about complications on full arches. And sure enough, the fact that we see more cracked teeth is suggesting that patients are exerting more force, more than the usual force. And so this is putting more pressure in the restorations that we fabricate for patients, whether they are tooth supported or they are implant supported. So on that note, let's go ahead and begin our webinar here. And let's start by looking at these images of a beautiful implant supported overdenture. This was not done by me. I happen to see this patient now in our practice, and we recall him. And in fact, we just admire this fine work of art that was done by a dentist in Florida 33 years ago. Now you'll notice you have a substructure that was milled, and then you have this overdenture that latches in place, but there's also some type of friction that holds it in place. And so again, this has been in service for 33 years, an overdenture opposing a complete denture. Now, today we utilize more sophisticated, more modern technology. Here you can see an implant support reconstruction that we did in both arches. That's holding on very nicely. Here you can see the aesthetics of it, a very smiling patient. And we wonder, how long will this last in the patient's mouth? How do these designs put up with, the pace of time? And so the idea today is to revisit numerous designs, and within these designs, to share with you some of our thoughts regarding our longitudinal assessment of the performance of these different solutions. And while we do this, we want to talk about how we've managed to navigate through complications. How are we managing complications in practice? And so I guess for the sake of being a little bit thought-provoking here, I want to suggest that the first key to managing complications is nothing other than to talk about them, and to talk about them before we even start treatment. As we do this, as we have this conversation with patients about the potential appearance of complications, well, this mitigates the effect of these complications. So when we're talking about how do we envision, the typical sequence, if you will, in therapy, well, we start with treatment planning, then we sequence therapy, and then we sequence how we want therapy to be rendered, and then we execute. This right here is going to be answering a whole host of questions, right? So treatment planning, why are we doing things and what are we doing? Sequencing, as in when should we do what? Execution, as in how do we do it, right? There's a very important missing piece of this equation here, which is the next question, which is the what if. And within what if, sure enough, lies the concept of complication. What if we encounter into something because of the whys, because of the whens, or because of the hows? So we got to be cognizant about the potential complication throughout all the journey of therapy, as importantly as the potential appearance of complications down the road. And so for years now, we've been talking about starting therapy with the end in mind, right? I mean, as far as implant dentistry goes, now it is a pretty common concept We don't place implants until we figure out what the end in mind is, right? Now, let me ask you this question. What is the end? Well, typically, we refer to the end as the day we deliver the prostheses. But I'm going to suggest to you that that shouldn't be conceived as the end. The end, on the other hand, should be, in our minds, the day that something fails. Because if we start thinking about something may fail, then right there, we're building, a system that has potential avenues to mitigate the deleterious effect of the complication. So during our 2-day seminar, Darren Deester and myself teach this decision tree when it comes to treatment planning and executing our full arch implant support restorations, either in patients that have a terminal dentition or with patients that are already fully edentulated. Now you will notice that in the top section right here, there's a rectangle. And this is the first part of our decision tree. And within this first part of the decision tree lies what we call the 5 elements, 5 key elements that we consider to select what type of solution we're going to be offering to our patients. Now, this right here is part of a Spear Digest article that it is sitting right there at Spear Digest. And Jerry's going to be nice enough right now to share the link to this article for all of you to have. Whether you are a Spear Online subscriber or you're not, you are welcome to look at our amazingly long library of articles in our Spear Digest. So anyway, Jerry here's going to be sending you the link to this article. And basically what we look at, what are these 5 elements? Well, you'll notice that we have 3 clinical elements and we have 2 actual personal elements. So the 3 clinical elements are the location. Where are we working, in the maxillary arch or in the mandibular arch? Then we look at etiology. What is causing the patient to be edentulous, or what caused the patient to become edentulous? Then we look at condition, which means the level of resorption of the ridge relative to the ideal tooth position and the lips. And then we have 2 areas that have to do with patient's preference, which is, on the one hand, patient's compliance to what therapy entails, patients adhering to what therapy entails, and the patient's financial capabilities. Now, if you think about it, when we talk about complications, 2 of the areas that stand out within these 5 elements are, on the one hand, the etiology, the reason why we're losing the patient's teeth to begin with, and the patient's ability to adhere with our recommendations. And normally, these 2 have a very important influence towards the if and when there is a complication. Now, let me point out, and this again is a pretty thought-provoking concept here, that nothing that is man-made lasts forever. And this has to be part of our initial discussion with patients. You see, if you look at different body part replacements, looking at limbs, looking at hips, looking at eyes, nowhere is it written that none of these replacements are thought of as permanent. In fact, they have an expiration date, if you will, that is way shorter than what we expect for teeth and implants more often than not. In fact, I just went for fun to Google this morning, what has it said about complications with hip replacement? And you'll notice there are well over 16 million results. If you look at complications with breast implants, you're going to find close to 6 million results. This takes me to an article that I wrote a few years ago, and again, Jerry's going to send you the link of this digest article that I decided to call The Biggest Dental Lie, because, in which I believe is that this notion that implants are forever. And I believe it is so important for us to have these discussions with patients that there is no such a thing. There is no such a thing as implants are forever. And the day that we treatment plan whatever it is that we're going to be doing, we have to be crystal clear with our patients, letting them know that there's no way we can promise, we shouldn't even attempt to promise that what we're doing is going to be in their mouths forever. And one of the reasons why I talk about this is the notion that the oral environment is a very hostile environment. On the one hand, there are tons of bugs, microorganisms that, you know, get organized and create problems. We thermocycle, right? And we use our teeth for things other than what we should utilize them. We parafunction. And so this makes, again, the mouth a pretty hostile environment to whatever restorations we choose to give to our patients. And so when we talk about treatment, what are we really talking about? Is it really treatment? Are we treating patients? Are we curing patients? You know, for quite some time, we struggled during our, you know, putting together our seminar, and we said that the best term that we should use is we manage patients' conditions. Because when we manage patients' conditions, there is right there between the lines this notion that to be continued. It's not a happily ever after, but it is a continuum of there's a whole story that unravels when once we are done, once we deliver the prostheses. We got to see how this holds into place, how patients look after it, how they take care of things, right? And so if we look at the literature, this is a very iconic article that was published in the early 2000s by the group in Loma Linda, Dr. Charlie Goodacre and his team, talking about clinical complications with implants and implant prostheses. You see, it's very interesting to read how back then, most of the implications behind complications were pretty much biomechanic. So what did they noted or they pointed out? Well, on the one hand, they saw complications when there was inadequate space for the different types of prostheses. They saw complications when patients exhibited parafunction, just as I mentioned briefly. They also saw a higher rate of complications when there was inadequate fit of the prostheses. And so these three elements right here are going to influence the incidence of complications appearing in our practices. So if you take a look at this, for example, these are two different examples of complications, but both of them exhibit the same problem. And both of them are showing here, most likely there was an inefficient or inadequate space for the prosthetic parts. And this basically calls for potential failure. And here you can see there's definite fracture of both of these prostheses. So if you look now at this systematic review article published by Papas Piridiakos, Chen Chuang, H.P. Weber, and Herman Gallucci in 2012, they're looking at 281 implant fixed complete denture prostheses, and they looked at them at a mean exposure time of 9.5 years. Now, the numbers are pretty unbelievable. Prostheses free of complications after 5 years are almost 30%, which means 70% of the prostheses exhibited some type of complication at year 5. When looking at these prostheses at year 10, well, then the number goes all the way to 91.4% of these patients are going to be exhibiting some type of complication. What we're looking at here is that complications occur continuously over time as a result of fatigue and stress, something we don't really think about and something we do not communicate to our patients as we should. So let's move along because I'm going to be sharing you numerous articles here. This one here talking about double full arch fixed implant support prostheses. So we have one opposing the other. Again, the mean follow-up here is going to be 5 years, and this is done by the same group, Papas Piridiakos, now with boarding, Nato, El Rafi, Pagni, the group from Eastman, Rochester, my dear friends, Akostas Choplidakis, Carlo Ercoli, and once again, Peter Weber. So what do they find here? Again, cumulative rates at 5 years. They talk about 50% of some sort of biologic complications, bone loss, periimplantitis. and again, 57% of technical complications. So again, you look at the numbers, these are prostheses free of biologic complications, 40.3%. Prostheses free of technical complications, you're looking at 42%, more or less. What they found, though, here is that the most frequent minor technical complication was wear of the prosthetic material, with an estimated 5-year rate of 49%. And when they look at the most frequent major complication, they looked at fracture of the material, and they saw this at an 8% rate. Now, here's another interesting article. Survival and complication from 9 to 15-year retrospective study. This one stemming from Sweden. So what they found here was 376 patients, 1,095 implants placed between 1999 2005. What are their numbers? Once again, pretty high numbers experiencing at least one complication, 65%. So if you think back at our little table here, this what if truly is more important than we care to recognize, right? And this is why in 2014, we actually wrote this article at Compendium in which I found that it was important for us to talk about contingency measurements, talk about what is the patient's priority and what are the risks, something I call the CPR protocol, which allows us to design a roadmap for more successful and long-lasting therapy. So what does this contingency thing mean? Well, contingency means there is a future event or circumstance that is possible. We know it most likely it will happen, but we cannot predict with certainty exactly when. This means that we are building in some sort of provision within our system. So consider this example. This is a beautiful case done by my mentor, Ralph Eudalis, in the late 90s, actually mid 90s. Ralph placed the implants and he restored this beautiful, beautiful, beautiful case. 8 implants, and you'll notice this is a cement retained restoration. Everything is splinted in one piece, metal ceramics technology. They went through post-ceramic soldering, which in itself is an art. Now, what happens if this patient here bites a fork and chips the ceramics of, or shears the ceramic of one tooth? It's going to be a very challenging repair here. It almost entails doing a lot of this dentistry back. So back then we suggested, well, from a contingency standpoint, an alternative would be, instead of splinting everything in one piece, what if we segment the arch into 3 different sections? What if we, instead of doing this cement retain, we do it way more retrievable and we start doing this screw retain? So you'll notice that this alternative here, if something were to break, now you are not forced to redo the whole thing. Now you can basically just go back and do one of these 3 sections. So take a look at these 2 alternatives: splinted cement retain versus segmented screw retain. So clearly you can see or start seeing advantages in the variables that you see in the case where we're segmenting and screw retaining. Right, so CPR, contingency, priority, risk. What are the risks that we see when we are figuring out what may happen with our treatment? Well, patients present different risks, and our acronym at Spear, as you all know, is EFSB: aesthetics, function, structure, and biology. And so depending on what is the risk the patient presents, we then think about a contingency plan to figure out, if there is this risk, if this is the reason why a patient is losing his or her teeth, what can I do to mitigate the potential deleterious effects down the road? You know, with every diagnosis comes a prognosis. So it's very important that as we assess risk, we think about prognosis. And as you know, we can think of either an unfavorable, a questionable, or a favorable prognosis, right? And so this really is influenced by 2 different variables here. On the one hand, if we have a known versus an unknown etiology. On the other hand, if we have a patient whose predisposition has either resistance or susceptibility towards one of these risks. You know, there are some patients that are very susceptible. There are some patients that are pretty resistant. I'll give you an example. You take a look at this patient that you can see that is fracturing provisionals all the time. You can see that there's definitely a predisposition here. Patient is susceptible to parafunctional activity. And so this can right here become an interesting variable for us to consider as to the longevity of, regardless of what the materials are, of the definitive prostheses that we're thinking about. We can anticipate that we're going to have to deal with this parafunctional activity. On the other hand, we may have patients that, turn on a red alert as far as biology goes, patients that are exhibiting more periimplantitis, and we are seeing more and more of these patients. We have to be very cognizant about this. So bottom line, when we look at our 5 elements, we need to think about etiology, we need to think about compliance, and the way these two will intertwine. All right, so we've laid the foundation. Now I want to walk you through numerous patients and to let you know what it was that we encountered and how we dealt with these potential complications, right? So let's start with this lady whom we've restored many years ago. Now she's probably in the 14-year range that we've restored. And when she came in, she had this terminal dentition. And what we provided back then was a conventional complete denture for the maxillary arch and a fixed hybrid for the mandibular arch. And so here you can see images of the prostheses, radiographic evaluation of what it looked like the day that we inserted this prostheses. And of course, we give patients all sorts of hygiene instructions, etc. We ask them to come back so that we can be recalling this patient. And sure enough, this patient right here decides not to come back. In fact, she waits 13 years to come back. So when a patient calls and says, I'm going to come back after 13 years, there's no way you cannot expect that something went really wrong, right? Maybe she lost an implant, maybe she fractured the prostheses, maybe she fractured some teeth. Something had to happen, right? Interestingly, this is exactly how she looked at the 13-year mark. You'll notice things look stable. The bone levels look stable. What was really interesting, though, is to see the buildup of calculus, of tartar, inside the configuration of the implant. And in spite of it all, you saw those bone levels. So what is this telling us? That this patient right here is a pretty resistant patient to develop periodontal conditions, periimplantitis. So we went ahead, steam cleaned it, we polished the prostheses once again, changed the screws, and sure enough, we delivered this back in place. So again, a very resistant patient with a fixed detachable with denture teeth. Now let me share with you this other example of this gentleman that, again, we restored many, many years ago, and this here is a ceramic reconstruction. Now, an implant-supported ceramic reconstruction. Now, as you'll notice, and being consistent with what I just told you, we managed to segment this arch into 3 different pieces. Again, from a contingency standpoint, if something were to go wrong, we're now rehabilitating the mandible in 3 different segments, right? And so as I said, here you can see images of the anterior segment before being inserted, and once we insert and we then go ahead and obliterate the screw axis holes, and we seal off the axis with composite. Well, first some Teflon tape and then composite. So what happens with this patient, and I've seen this patient before, but I want to share the way he looks at a 10-year recall. And this patient, and excuse the grossness of these pictures, but I had to make a point here. What you're seeing here is a patient that definitely, it's not a very compliant patient when it comes to hygiene. Again, plaque, calculus all over the place. What would we expect? Well, we probably would expect to have considerable bone loss. So we go ahead, we clean him up. As we look at his radiographs, and this, again, a 10-year mark, you'll notice, even in this periapical radiographs that this patient, when it comes to predisposition, is pretty resistant when it comes to periodontal breakdown, peri-implantitis. Not to be said about every single patient, but you need to call these things out. You need to know who's who in your practice, right? Anyway, so then let's move along and let's start seeing what potential complications we can bump into. So this is your double arch fixed hybrid patient, and we've been following this gentleman here for quite some time again. You'll notice here 4 implants in the maxilla, 4 implants in the mandible. This is a titanium and denture teeth fixed hybrid, your conventional hybrid. This is what things look like. This is what things look like at a 4-year recall. Again, we have to reinforce hygiene instructions to these patients. Sometimes they're motivated and they do a good job. Sometimes we start seeing a lot of plaque buildup. We utilize our patient education videos to try as much as possible to encourage them to do a better job with hygiene. At any rate, this is how he looks like. We then, once we remove it, we go ahead and seal it back with Teflon tape and composite. Patient comes back at a 5-year recall. Again, the tissue looking a little bit angry, especially in the maxillary arch and those 2 anterior implants. And sure enough, send him back home. Then he comes back because he got hit in the elbow. Now, this right here is a pretty, I'm gonna say, common minor complication of fixed hybrids, right? So how do we deal with these type of complications? Well, looking at the literature, I found a very nice technique piece at the JPD, Journal of Prosthetic Dentistry, that was published in 2005 by Bill Abu and Mike Razug. I believe they are from the University of Michigan, in which they walk us through a procedure for repairing fixed hybrids. Now, in their example here, as you'll notice, the tooth got delaminated all the way to the metal. So what they need to do here is you air abrade with aluminous oxide, 50 microns at 50 psi. Then you apply a thin layer of metal adhesive primer, then 2 coats of microfilled composite as an opaquer, and then went ahead and microfilled resin composite. So they're doing this directly. Now, when it comes to Mo, our patient, we decided to do this indirectly. In other words, to do the repair, remove it from the patient's mouth, and then work in our lab bench, which we think we can do a much better job, much cleaner. And so, again, we start here by sandblasting. Then you can etch both surfaces, and this is phosphoric acid. Then steam clean the surface, make sure that there's no debris of any sort. Then start adding some bonding agent. What we're going to be utilizing here, we heat up some composite so it flows nicely, and we're going to now seat the fragment that the patient has. When the patients don't bring the fracture fragment, then I guess we need to either wax it up and then do a matrix or freehand with composite that repair tooth that we need to do. Again, here we hit it with a light, polish it off, and here goes the patient with the repaired dental central. And again, as I said, this is a fairly common complication for us to deal with in practice. This gentleman here is yet another one of those patients with no proprioception. He's got double arch, he's got fixed eye hybrids in both the maxillary arch and the mandible. You'll notice what a nice aesthetic outcome we were able to manage when we inserted these prostheses. Again, these are 2 views of what was delivered back then, both maxillary and mandibular arch with fixed hybrids. A couple of lateral views here for you to appreciate how things look, and radiographic evaluation of the case in place. So what happens at a 4-year mark later? This patient is a particularly interesting individual. He's got some traits that make him even more interesting. 3 of them, if I may say. The first one, he's a lawyer. The second is he's a hunter. The third one is that he smokes cigar. He's a heavy cigar smoker. So, you know, he's out there hunting, and he is not compliant at all. And he uses his teeth to open stuff that he shouldn't be using them with. So sure enough, he comes back to see us like this. And as I mentioned with Mo, the previous patient, this is a very straightforward repair. as I previously mentioned. So we go ahead, we now repair the tooth back in place. Having said that, our patient goes back to the Northern Territories. That's where he loves haunting, in the Northern Territories of Canada. And as I said, he hardly looks after his teeth, not complying at all. And so what happens when he, as I said, he opens up things with his mouth? God knows what he does with his teeth. And so sure enough, you can see some of this denture teeth popping out. And what does he do? Either A, he's going to visit a very, very rural dentist that he potentially may find, or B, he may go ahead and get some crazy glue and crazy glue those teeth himself. And so he starts coming back and forth, and he starts to get pretty annoyed about this happening recurrently. And so he basically asks, can we do a better job? Is there anything we can do to mitigate or to eliminate this from happening? And sure we can. We can think of utilizing different materials. So instead of utilizing a fixed hybrid approach to the maxilla, we're now going to be doing a monolithic zirconia solution in the maxillary arch. Now this is going to be opposing his denture teeth hybrid, which now in hand will become, if you will, the weaker link of the system. Now what we want to see here is these teeth wearing and eventually us being able to reveneer these teeth. Because normally the ones that he was popping out were the maxillary teeth. So here you can see now the new solution here, a zirconia implant supported fixed dental prostheses opposing a fixed hybrid. And different views here of the way that this prosthesis integrates. And as you can see here, a pretty happy patient. Okay. All right, so let's move along and let's start adding some layers of complexity here and start seeing what potentially can happen other than just having one of these denture teeth flake off or be chipped, right? So this gentleman we treated quite some time ago, a very, very dear patient of ours, Sergio here. So he came in with this dentition and we decided to place implants in both arches. And what you see here is the transition of tooth supported to implant supported. And the patient's here wearing some provisional restorations. Now this patient, for all his years, was quote unquote dentally crippled, if you will. He had some partial dentures, ill-fitting partial dentures. He had all this wear. He could barely function, right? But this is what he was utilizing. And so now we give him fixed implant supported restorations in both arches. Now there's a very interesting quote that comes from the engineering world, which is, any mechanical system will be as strong as its weakest link. So, you know, the patient had teeth that had mobility, had a lot of wear, he had a partial, everything was wobbly. Now you give him fixed restorations in both arches. What is the weakest link of this system? And so as I said, with him, in fact, we did immediate loading protocols. So the implants integrated very nicely, but sure enough, within provisionals, he shears off this part of the provisional. You notice how this segment of the maxillary provisional basically comes out. So then we have to go back and, of course, do a quick repair in the office, which we normally utilize some wires and acrylic. So we cut a little trough, we fixate the wires, and then we add some acrylic. And then we moved swiftly to make some records and essentially have the laboratory fabricate the definitive prostheses. So in an individual like this that has multiple implants in both arches, what is the ideal solution for him? What is the potential built-in contingency plan that we were talking about a while ago? And so this is when we thought about incorporating the concept of these similar materials for the first time. So you notice that in the maxillary arch, we're utilizing zirconia, and we're going to be layering ceramics on top of the zirconia. And in the mandibular arch, we're utilizing titanium, and we're going to be layering those with denture teeth. Kind of like how we repaired our Hunter patients that I showed you a little while ago. So in any event, this is right here how the design of the frameworks look like. And here you can see the definitive prostheses. Zirconia framework with layered ceramics in the maxillary arch. Titanium framework with denture teeth in the mandibular arch. This right here is the intraoral view of the reconstruction. And here you can see an extremely happy patient. And you're able to see right there in the black and white picture, that metal clasp showing of that original RPD that he had, which kind of looked like a bottle opener. And then a very brilliant smile of the patient once we've restored him with our definitive protocol here. So we discussed with him, being that he fractured the provisional, that from a contingency standpoint, we want to utilize the similar materials. So sure enough, 2 years later, patient presents with exactly the condition that we spoke about that was going to happen, which is an intact maxillary arch, but a worn, heavily worn denture teeth in the mandible. And so, since this is something we discussed with the patient previously, he looked at us as, wow, yeah, this is something you said. And now the patient is more than compliant and more than happy to pay for that reveneering. And so what we need to do is to reestablish the vertical dimension. So we add a little bit of GC pattern resin to the vertical that we want, and then we make our intermaxillary record. Now back then, there was this new material that came out, nanohybrid composite teeth were called, which claimed to be way more resistant. So sure enough, this is how we had our technician go ahead and reveneer these teeth. And very simple, very straightforward. We go ahead, we now place the new reveneered lower, the upper stays pretty much intact. We torque our screws, life is good, patient goes home. 6 months later, I get this phone call, and the phone's ringing differently. You know, I never hear the phone. That day, I heard the phone. Sure enough, my assistant tells me that it's Sergio who wants to talk to me. So he says, I think I need to come see you immediately. I said, sure, go ahead. I'm assuming he's coming because he chipped. Perhaps we had a processing error. Perhaps he chipped some of those lower denture teeth, right? Well, much to our surprise, when he comes in, he looks like this. What happened to my brilliant contingency plan? Now he chipped the ceramics that I told him were going to stay in his mouth for a long haul. So now how on earth do we restore this? Well, the first thing we do is we take a deep breath. We put this back in the cast, and by the way, I have some prototypes that I had made from him initially, so I put back those provisionals that we had for him. And going back and forth with our technician, we thought that probably the easiest way to restore this is if we prep the 4 anterior teeth for veneers, and then we did 4 ceramic veneers, 2 pairs of 2 ceramic veneers. And so here we are trying them in, and then we go back and we're going to be etching both surfaces with hydrofluoric acid. Then we go through silination of the surfaces, and we go through the bonding protocol. And this becomes an extremely straightforward, simple repair for this type of fractures. The other thing that we did was that we reveneered the lower. We removed those nanohybrid composite teeth, and we went back to, you know, our typical, you know, peanut butter teeth, those that wear very nicely. We don't want to expose this patient to having these 2 dissimilar materials when we have such resistant to fractured teeth in the lower, and in a patient that we know is clenching and we know that it's exerting this type of pressure. So here we have now the reconstruction delivered. We go back in, we torque our screws, obliterate that, and we're good to go. And by the way, I'm happy to tell you, take a look at the date on this article here. By fluke, this article came out in our Spear Digest today. You see, October 7 right here. So Jerry's going to send you the link to the article in which I walk you precisely through all the different steps that we took in order to fix Sergio's chipped ceramics via those ceramic veneers. Anyway, don't go anyway. Now it's 4 years later. He comes to see us. Now what? Four years later, things are looking good. And again, I want to do a longitudinal follow-up so that I can show you what things are looking like throughout all these years. So probably a little chipping of the lower incisor, but other than that, things are pretty good to go. At 6 years, he comes back and says, you need to see me. Okay, I go, is it my veneers? I'm like freaking out about those veneers. No, he broke, or he flared out one of those denture teeth, which by the way, was a very simple repair that we were able to do intraorally, following the protocol that I have previously described. Let's move along to 9 years. In 9 years, you start seeing here a Sergio that starts looking more aged. You start seeing now how his ability to be doing a good job with hygiene is a bit impaired. So we have him on a more tighter recall. He comes to see us every 3 months. This is now at 12 years. He comes to see us and he claims now that he feels something funny in the lower left. We take a close look. Now what? Now Sergio has fractured the titanium framework at year 12. Now, not much we can do about that because he fractured pretty much at the cantilever, which means now that we need to CAD-CAM generate a new framework and to reveneer the lower. Now, being that we had this discussion with Sergio since day one, this has become a non-issue throughout all this time. So sure enough, the upper is standing beautifully. We go ahead, we deliver now the lower, and here now is the smile on Sergio's face, and you'll notice how clearly he's been deteriorating because sure enough, Sergio has been aging. But he's moving along, and I've shown you a 13-year follow-up of his case since day one. Now let's move along, and this is another interesting case. This here is Rosie. We did, again, 8 implants for the maxilla, 5 implants in the mandible. These are her prototypes. And back then we were thinking, again, from a contingency standpoint, we're gonna be utilizing the similar materials. I felt, okay, what if we utilize zirconia in the lower as well? And here you'll notice that we have zirconia frameworks both in the maxilla and in the mandible. The only difference is that we're layering the maxillary arch with ceramics, we're layering the mandibular arch with denture teeth. So pretty similar to what we did with Sergio, the similar veneering materials for this solution for her, right? So here's the prostheses once we insert them, and this is here the facial or dental facial aspect of the reconstruction. And back then we thought, okay, so this is a contingency-driven design. It's retrievable, it's easily repairable, and it's predictable. In fact, this is part of a book chapter that we wrote on designing fixed implant supported reconstructions for the edentulous patient. This is part of the volume 2 of the interdisciplinary treatment planning texts by Michael Cohen, which are both great books with incredible chapters by amazing clinicians. Anyway, at 2 years after the fact, what do we see? Everything looks beautiful. You'll notice here how both the maxillary arch and the mandibular arch are holding up very nicely, right? Even in these close-up views, you'll notice that things are holding up very nicely. Let's fast forward to 8 years later. What happens with Rosie? She says, oh, you're gonna kill me. I bit on a fork and I chipped the ceramics of one of my front teeth. This happens to be the canine right here. So what is gonna be the way that we're gonna be restoring this type of complication? Well, it's fairly similar to what I told you with Sergio. We're gonna be doing a ceramic veneer. Now, as I said, we could go ahead and repair this directly. We could prep the ceramics, make an impression, and then send it to a lab for them to pour a cast, or do it indirectly. We remove the prostheses, we place the patient's prototype right back in, and then we fabricate a veneer. Same protocol. hydrofluoric acid to both surfaces, both the veneer and where we prepped within the reconstruction. And then we are gonna go ahead and cement our veneer as conventional as it gets. It's very, very straightforward. And so once this is ready to go, we're ready to insert this back in place. And here you can see the before and after the repair. And let me blow this up for you so that you can see right here how easily we're able to address this type of situation. And again, when we talk to patients about these types of things, people are going to ask, who's going to pay for this? Well, for sure the patient's going to pay for this. She bit a fork in my ceramics. Why should I pay for this? And this has been holding on for many, many years, right? 8 years. So she's happy to pay for the veneer, and she's happy that we're able to help her through such a smooth procedure. Okay, so let's move along, and let's go all the way to 11 years follow-up. And now she comes in because she cannot stand how those lowers look on her. And you'll notice how beat up they are. And of course, this is something that was expected from the get-go. In fact, this is right here what we planned to happen, right? She's gonna be wearing the lower teeth, and it's gonna be very straightforward for us to reveneer these teeth. So we retrieve it from the mouth, send it back to the lab, remove all the acrylic, and then have the technician reveneer new denture teeth, and off we go for the insertion of our prostheses. It becomes an incredibly straightforward protocol. Now, what you need to consider though is that the key here is to keeping the prototype so that when we're doing any type of repair, when we remove the prosthesis that we're repairing, in goes the prototype that we have in a box waiting for her, just like we have spare tires waiting in our cars if and when, you know, we get a flat tire. And in fairness, today with CAD/CAM, it is so easy to mill a prototype and to have it ready to go. And so have these discussions with patients, because when you talk to them beforehand, then it becomes a very straightforward repair. You don't suffer these repairs. Which takes me to this case, which is a rather more extreme case, if you will. An implant supported fixed down prosthesis that we did for this gentleman years ago, beautiful ceramics, opposing natural dentition. And you know, this patient was your typical patient that's fracturing provisionals day in and day out. And you know what they're fracturing, what they're eating when they fracture, right? It's always soft bread, right? So you have to have, by the way, we have a nice digest article called My Crown Broke Eating Soft Bread. You may want to check that out as well, because I give you the biomechanical explanation of the bread not breaking anything, but the bread being chewy and basically bringing that fractured piece that was already fractured. So there was a crack propagation, and so the bread just brings that piece. So, you know, this is what things look like, as I said. And we had that discussion with the patient. I said, let me tell you something, Ray. The problem with you is that, and in fact, I showed him these images. This is a case that I presented at a big Ivoclar ceramic symposium in San Diego like 10 years ago or so, or 8 years ago. And I told the patient, I showed him the slide that I showed during the presentation. I said, Raymond, your problem is that you are the ultimate terminator. And you're gonna break something at some point. And he laughed when I showed him this. So again, what is the weakest link with Ray here? Well, we can think of either one of these, either the framework, the abutment interface, the abutment screw, the actual osseointegration, or the opposing dentition. So what happens 5 years down the road? Sure enough, boom, he fractures the framework. So now what do? Well, the first thing we do is we tell him, I told you, right? And he goes, yes, you told me. Anyway, he's not happy. I'm not happy. But let me share with you what we did, and it worked for a better part of a year, which is a very cool reparation protocol here. So hear me out here. We seat these back in the master cast. We're going to sandblast with aluminous oxide, 110 microns for at 2 bars. We're going to salinate 1 minute per surface. We're going to allow 5 minutes for the silane to evaporate. Then we're going to apply our bonding agent, and then we're going to go ahead and utilize our cementation cement, dual curing resin cement. We put it back together, and it goes back into the patient's mouth, as you can see right here. This actually lasted for a full year until Ray said, okay, I think we should move on and go ahead and do a new one. Now, when it comes to the new one, it shouldn't surprise you that what we did, and there's the initial design. You'll notice here that our new design here is way huskier, much more robust. This is a CAD/CAM generated reconstruction. So the information, the technician had it in the computer. So redoing this was not all that cumbersome. What we did though was we beefed up the thickness of the ceramics to ensure that now this goes, this provides a more robust prosthesis and hopefully would last longer. Now, I'm very, very sorry to tell you that unfortunately, and these are the last pictures that I took from Ray, unfortunately, right after we inserted the prosthesis, a couple of months, he was living abroad, and before he came back for his recall, his wife let us know that he unfortunately passed away. And it's very, very sad because, as you all know, we develop long-lasting relationships with our patient, and he was a sweetheart of a guy, and it was a pleasure to treat him. And unfortunately, as I said, he didn't make it. To continue this journey and to be sharing with you more of what happened after the fact, right? So let's summarize here. So we've been talking about a lot of components, a lot of different pieces of information. The first one I want to point out is that here's an evolution of what frameworks used to look like and what ceramic or zirconia frameworks look like today. In fact, today we're more and more going towards the monolithic approach in which everything is pretty much one piece. So this right here does provide a much more robust solution for our patients, right? We talked about numerous types of complications from, fragments of the denture teeth fracturing, from fragments of the ceramic fracturing and the fabrication of veneers, from actually frameworks fracturing. Now, let me circle back to those articles that I shared with you initially, because they very clearly state that these type of complications may occur continuously over time as a result of fatigue, as a result of stress. So this is something that we should expect. We should stay away from telling patients that what we're doing is going to be lasting forever. The other thing that you can readily see here is something that's inevitable. This is a quote by Clark Stanford. I heard him say this in a meeting years and years ago. Our patients age underneath our fancy, sophisticated restoration. So remember, this is an ongoing process. Remember, the intraoral cavity is a very hostile environment. So when we're dealing with complications, ultimately, we need to think about three things. The first part has always to think back and revisit what was the patient's etiology to begin with. Why did the patient lose his or her teeth to begin with? Because there's a very big chance that this etiology is going to come back and haunt us one way or the other. The second element has to be patient's compliance. These are patients that need to understand, just like when they buy a very fancy car, they cannot just disappear from the leadership. They have to go back. They have to be recalled. They have to be compliant as to what they can do. If you buy a beautiful car, you know you cannot go through a rocky road. You're going to mess it up, right? Same deal here. I mean, patients have to be cognizant and compliant about what they can do and what they shouldn't be eating or doing with their teeth. And lastly, we got to think about our prosthetic design. And with design, there's a whole host of things that we have to consider. The optimal space for the different materials, the type of reconstruction that we're going to be doing. Are we going a fixture level? Are we going abutment level? Are we doing full fix with zirconia? Are we going to do with fixed hybrid with titanium and denture teeth? Again, these are all elements of design that have to be very well thought of. Next, we need to talk about the concepts of treatment as a management, as a continuum. We handle your situation. We are going to be able to tackle whatever complication we encounter, but there will be complications. And, you know, we got to use this word management and maintenance. We got to give these prostheses maintenance. So with this in mind, I want to wrap up, because I know there are a couple of questions, sharing with you this beautiful image by La Pedrera. This is in Barcelona by Anton Gaudí. And you'll notice how perfectly maintained this is. Gothic architecture from early last century, right? And I want to overlay this now, or layer this with this beautiful, beautiful design by Norman Foster. This is the Reichstag in Berlin that was bombarded and now was created with this beautiful CAD/CAM technology. So, you know, something to be said about how do we handle, you know, those reconstructions that we do? How do we maintain them? And if and when they fail, how we're able to go back and repair them utilizing technology. So before we wrap up, just a quick reminder. We have a 2-day seminar in which we teach for the course of 2 days all the bits and pieces we need to be thinking about as we treatment plan the terminal dentition, the periodontal patient. We have actually one seminar coming up in a couple of weeks. Maybe some of you would be interested in registering. Maybe you want to hit the link that will take you to Spear Online, and you can understand or know more a little bit about what we do. Lastly, I want to leave you here with my email and my Instagram account. Should you have any question that you want to address, or if you want to have any article that I talked about, or other articles that you may want to reach out to me, please feel free to do so. And on that note, I'm going to stop here.
All right, guys. Let me exit this. Stop sharing. There you go. I'm sure everybody stayed awake on this one. Okay. Well, Spear is definitely an organization that I'm going to be a member forever, because there's so much to learn, so much. Now, all right, this is a moment for us to take home messages. Let me eliminate this. Let me stop it. Okay, here it is. Take home messages. I'm going to start with you guys. I took little notes. Steve, take home message.
What I walk away from is take away my arrogance and discuss what can happen with realistic expectations.
Yeah. It's beautiful that he puts this perspective of 5, 10, 13 years and situations that we could have wonderful year or two success, but what happens 5 years later or 10 years later? It's really nice. Ricardo, I'm very lucky to have become friends with him. We text, we talk, and he's incredible. Brent, how about you?
I like the concept of everything is management and maintenance, that and the analogy of the expensive car, that, and Cunning Dental uses that. If you can afford a new car, you can afford teeth in a day. Well, that's true. You can drive off the showroom with a new car, and you're going to walk out of there with new teeth, but the car isn't going to last forever and never, and so are the new teeth. They're not going to last forever either. I think a lot of patients come in and they think it's a one and done type of situation. They're putting in $50,000, $60,000, $70,000, and they're going, okay, now I'm set for the rest of my life. I'm looking at a younger patient. He's in his 40s that's looking at All-on-4. And then I've also got the patient that you and I are working with, age-wise. you know, for Richard, his prosthesis will probably last for the rest of his life. For my other patient that's considering it, he's going to have to really seriously consider redoing things down the line and for some money. So these are concepts that really been instilled in my mind that I've got to incorporate it into treatment plan for the different age brackets that are going to be looking at these type of prostheses.
It's interesting. We are using the analogy of Ferrari, expensive car, because I tell patients, this is your Ferrari. It does its maintenance, and then maintenance has an expense. First year, no, it's part of the package. But after that, you know, depending how you manage the compliance, etiology, could be twice a year, or could be once a year. And the, you know, reality of one thing he pointed at is double arch. He referred to as no proprioception, so they're banging. So yeah, it was nice to see the variety of cases it showed, and we saw the consequence of some of those decisions moving forward. What do you think, Anna?
You know, two things, you know, parafunction and hygiene, very important. Either one of those can kill the, you know, no matter how good the prosthesis is. And, you know, just to emphasize that in the patient, and especially now, you know, with COVID, you know, like, you know, you see a lot of more prevalence in, you know, broken teeth and fracture, you know, restorations and all kinds of stuff. So it's important to inform the patient. So in the case that something like that happened, they are not shocked, you know, and they don't come and blame us, you know, but they take responsibility.
What was interesting, for all my All-on-4, I don't tell them go buy Waterpik. I give them Waterpik.
Oh yeah, you do. It's
this is my gift to you. Yeah, and yeah, he didn't touch biology. He at one point he talked biology 50% after 5 years. One of the articles. If this was all design. Yeah, you're right. Absolutely, hygiene. And let's see, Roya. I'm going through what's in front of me, guys. I'm just not going in any order. Roya, no, okay. And Heather, any input? Some are shy. It's okay.
Okay, I'm here. I can talk.
You're,
Oh,
on my
you're-
list, you're next, Susan.
Okay.
You're next.
Lyndon Cooper gave a seminar not too long ago. I don't know what I saw that on, whether it was an AAED presentation but he started out by talking about All-on-4s. Everything breaks. And he goes, and what doesn't break gets peri-implantitis. I mean, his whole lecture was about problems with All-on-4s, but there was not one part of it about implant failure. What's your contingency plan if you have an All-on-4 and all of a sudden it's an All-on-3? So I'm sure that's a completely different lecture, but it is remarkable to me that people go, oh, this is going to last me the rest of my life. And I said, do I look like God? And God gave you a set that lasted maybe, 20 years. I said, I'm not better than God. It's not going to happen. This is going to need repair and maintenance. And I say the same thing. It's a Ferrari. It has to have a lot of maintenance. It's going to have new tires. It's going to have oil changes and new screws and things like that. But I mean, it's amazing how people just think you're going to do that and everything's going to be perfect the rest of their life. I don't know why that is about dentistry.
I know, Susan, funny that you say that. I do make the statement about their natural teeth that was meant to last them a lifetime.
Yes.
And they're being replaced. So they shouldn't expect this to last them a lifetime, but with maintenance and more care, we'll do our best. Yeah. Yes,
we'll do our best is exactly right. And I can't reproduce all the bone that they've lost due to gum disease and the loss when the teeth were extracted and the parafunctional bruxisms they've had. I don't know. I pick up my mouth mirror and I go, This is not a magic wand that I wave over you.
Yeah. Now, Mary, my hygienist,
Oh,
I'm lucky, isn't it?
I
Mary sees biology for single implants. They should have full access for brushing and flossing.
Yeah.
And how often do they have periimplantitis, Mary?
Well, I wanted to make a comment on the other thing. First, I like the idea that you're telling them, you know, that this isn't lasting for life, that they're going to have to, you know, take care of them. But do you remember, Dr. P, you had another course, and I don't know if it was for the doctors or if it was one of the hygiene ones, but it was a hygienist that presented it. So I think it was for the hygiene.
It was for hygiene.
And the hygienist, it was from Florida, and the hygienist, it was directing it to somebody who was getting like a full, I think it was All-on-4 or something. And she said to this gentleman, she said, he felt like he was going to be done with everybody. And she said, no, we're going to be married. You and I are going to marry the rest of your life. And but one thing I thought was really interesting, and you might remember this, that I got out of that lecture, is she puts all of the patients on the Oral-B electric toothbrush, and she has them use the the pointed one that's supposed to be used in between the teeth. She has them use that and works that underneath the prosthesis to try and clean as well as they can. And I thought that, I learned that from that class, that I thought that was interesting.
Only if it's designed correctly. If it's not enough, the space is not there, and it becomes a ridge lap.
You can get underneath. Yeah, well, apparently she worked for a guy that gave her room. But anyway, I thought that was an interesting, and of course, water pick, you know.
They can't floss, so water pick, and maintenance. Bring them in.
Yeah.
And what was interesting, I will talk to Ricardo about this. If we say the patient came back 5 years later, does that mean they didn't come back in between? So what happened to the soft tissue? Show me the picture of the soft tissue. No, it was more mechanical.
They don't come in for a year. I can't imagine.
I have a lot of those pictures.
At least perio patients. I mean, they're horrible.
Well, I hope you enjoyed it. I've seen this video. I'm telling you, when you look at it again, it brings back more information. And depending on our mindset, we gather more for our own personal benefit. Let's see. I like it when he says, take a deep breath when the case comes in. I like it when he talks about the prototype, which is keep the case, the box, and these things 5 years, 10 years later could become useful with implants. And these are things that I wrote down. So I think any last comment before we say goodbye, because I promised to finish before 9, and I go home to see how the kids did first day back to school.
Say good
All
night.
good? Time to go? Good night.
Good night.
See you guys. All the best. Thank you.
Good night, everybody.
Good night.
I love Dr.